Expertgruppen för biståndsanalys, EBA, är en statlig kommitté som oberoende analyserar och utvärderar svenskt internationellt bistånd för att det ska kunna förbättras och utvecklas. EBA har 10 ledamöter med kompetenser från olika biståndsområden och ett kansli som verkställer besluten. Förutom våra rapporter så ordnar vi seminarier, workshops och möten mellan olika parter. Varje år sammanfattar EBA sin verksamhet i årsberättelsen Biståndsanalys. Den kan beställas från kansliet eller laddas ner på eba.se. EBA har ett oberoende i relation till uppdragsgivaren regeringen, liksom i relation till vad som utvärderas, samt till de rapportförfattare som anlitas. Rapportförfattarna ansvarar själva för slutsatser och rekommendationer i sina studier. Allt vi producerar som rapporter, seminarier och vår podcast EBA-podden finns tillgängligt på vår hemsida.
Starting off well, warm welcome everyone to this seminar arranged by the expert group for AIDS studies, where we will hear about and later also discuss and learn from each other around the topic, does SRHR aid work? And look at the knowledge and evidence that we have to understand that better. My name is Julia Schalk. I'm the Vice Chair of the Expert Group for AIDS Studies, and I'm also a Director of Policy and Program Partnership at WaterAid here in Sweden. And with these seminars that we arrange, we want to create a platform for learning and listening and discussing different topics of development cooperation. And today, as I said, we're launching the report, The Role of Aid in the Provision of Sexual and Reproductive Health Services. And we will hear from the author team. They are all here today. It's Jesper Sundewall, Björn Ekman, and Jesse Schmidt, all from Lund University. And today's agenda, we will first hear a presentation of the report itself, and then we will have a panel discussion around the findings of the report and broader questions related to what gaps do we know of already in terms of knowledge about the role of aid for sexual and reproductive health and rights. And we will hear from SIDA, the Swedish International Development Cooperation Agency, also IPPF, the International Planned Parenthood Foundation, and African Population and Health Research Centers, all having person here representing these organizations to reflect about the findings of the report. In the end, when we have about 20 minutes left of this seminar, we will also invite all of you listening in to this webinar to come to have questions. And I ask you to use the Q&A function in the meeting, and I will then share your questions. So without further ado, I'm going to wish you all warm welcome and hand over to Jesper Sundewall to present the report.
Thank you very much, Julia, and I'm delighted to be here today, and on behalf of the entire Water team, colleagues Björn Ekman and Jesse Schmidt, we would like to thank you for taking time to join us here today, and we're looking forward to a really, really interesting discussion. I would also like to say thank you to the EBA for this opportunity to write this report. We're really grateful for that, and for the valuable input from the reference group, consisting of several experts in the field. And I would finally also like to acknowledge the contribution of Master Public Health students Pia-Marie and Anja, who have contributed to some of the work of this report. So with that said, let's dive into it. Let's ask the fundamental question, does aid work? You know, when we talk at university, we like to pose good questions, and this is a good question. Does aid work? And hopefully, you know, this report will provide maybe a small piece of the answer to that question. Maybe not the full answer, but let's get back to that, because it is a good question to ask, although a very, very difficult question to answer. I'll spend the coming 15 minutes or so going through the report very briefly, So I'm not going to dive into too much detail, but giving you the broad strokes. And hopefully you have found the report on the EBA website and you're able to sort of dig into everything that you want to learn more about. But we have a standard outline of a presentation, some introduction, data methods, results, conclusions, and then some food for thought going forward. Now, why do we do this? So let's, we know that SRHR outcomes have improved over the last 20 years. We have one graph to the right in the picture, or to the left in your picture, to show this. Maternal mortality has gone down. This is from 2000 to 2017, and this is in low-income countries on average, right? So we have seen a significant decline. That said, we have huge disparities in these improvements, both across countries, but also within countries. And we know that SRHR services are necessary to achieve many of these outcomes. In order to achieve improvements in maternal mortality, we need good antenatal care. We need skilled birth attendants. So thus, that's a rationale for us for actually trying to look at services here. And we also, have some signs of these improvements that we've seen over the last 20 years actually leveling off. Björn and I were down in Zambia just a few weeks ago, and they see this now that neonatal mortality in the most recent survey actually went up slightly. And there's a worrying sign that this improvement is leveling off, or might even be a reverse trend, which is not good. So we need to further understand, what determines services over time. We have an analytical framework for our study, which we think is quite useful to give an overview of how we place our work. And we've done this in sort of a results chain or theory of change, where we go from inputs on the one side to impact on the right-hand side. And we highlighted the study focus in this circle of red, where we want to look at service outcome indicators. In this case, we're interested in modern contraceptive prevalence rate, skilled birth attendants, and ART coverage. And this follows a logic that on the one side, the Swedish government, other governments, they provide ODA, official development assistance, with what we then call inputs that contribute to different activities in the form of projects to achieve certain outputs, leading to outcomes. And at the end of the road, what we are, of course, really interested in is the impact. However, the reason we are looking at outcome and not impact is that when you get to the impact level, there's many, many more things influencing maternal mortality than only, SRHR aid. So trying to be a bit more specific in trying to understand, the effect of the role of aid, we chose to look at the outcome level. But of course, at the end of the day, what we want that outcome to achieve is an impact and improvement in these rates. So with that said, our main question is, what effect has aid had on SRHR services in low and middle income countries over the past 2 decades? We want to explore this effect across different types of aid. And I'm going to show you later on, we have 3 different types of aid that we're looking more closely into. We're interested if the source matters. We're going to compare, for example, bilateral and multilateral and see if we can find different effects. We're interested in seeing if the effect has changed over time. We're looking at almost 20 years of aid data, and can we see a difference over time? And finally, we have a question on, is there a minimum level required for aid to be effective? All of these questions, our report contributes to providing some answers to. There are several analytical challenges related to a piece of work like this. First of all, we have ODA measures are not always accurate, and we'll get back to that. Secondly, we know that SRHR services are determined by several factors, not only aid, and we need to control for them. We need control for what we call both observable facts, but also the unobservable facts. The observable might be slightly more easy, and we control for a number of them in this report. For example, we control for corruption, we control for population density, we control for government health expenditure, etc. These things that we actually have data on over time. But the model that we apply, or the method that we apply, the fixed effects model, it also allows us to control them for unobservable things. And that, we mean things that are relatively constant over time, but that we don't have data on. For example, religion could be one of those things. A final analytical challenge, or there are probably more, but a few of those we want to highlight, is that aid may be allocated on other bases than need. And it's not possible, to randomly allocate aid. There's no, we can't randomly allocate and see the differences in effects. And in the absence of randomization, we need to apply then different statistical models to try to minimize, to be able to isolate the effect. And we're then looking at this fixed effects model as one tool to mitigate that. If we go further into data and methods, well, we have a panel data set. And that means basically that we have a very big data set, you could say. But a panel data set where we have the same observations over time. So we have many data points on the same observations. For example, we have then aid on every year for these years over and across all these countries. We also have then on contraceptive prevalence rate, skilled birth attendance, etc. So creating this huge data set with observations over time. We apply regression modeling. We also then use this fixed effects model to control for these unobservable factors. And on top of that, we conduct a number of sensitivity analyses. For example, we deal with we look at the effect of incomplete data because we don't have, we have gaps in the data where we don't have data, for example, on contraceptive prevalence for a country a certain year. So we see if they, can we then control for that and see if that changes the results. We look at measurement error by creating average indicators over a 3-year period in time to make sure that we are not sort of, just looking at measurements error. And all the findings when we control for this seem to be in line with the main findings. So the sensitivity analysis don't point our results in a different directions, which is reassuring. We have indicators that we collected, just for those interested, come mainly from, say, repositories such as the World Bank Development Indicators and the WHO Global Health Expenditure Database. On the right-hand side, we have a figure showing, what is it we're talking about when we talk about aid. And we have 3 measurements, as we said, of aid. We have health ODA, we have population or reproductive health, or SRH ODA, and we have then specific reproductive healthcare ODA. And health ODA is, and this is the classification used by the OECD to classify aid and the way the official statistics on aid is reported. So health ODA is a broader measure. Population policies and programs on reproductive health, what we in the report call SRH ODA, is a slightly narrower measure. And then finally, reproductive healthcare is the most narrow measure of aid. So we use all these 3, but we focus on the middle, which is here called population policies, programs, reproductive health, and in the report, SRH aid, sector code 130. That's the main measure. And I should say now we're looking at all SRH aid globally. So it's not looking at the effects of Swedish aid, and it's just worthwhile emphasizing that point. So what are the results? Well, in a nutshell, we can summarize that aid has a small but significant effect on SRHR services outcomes over the period. I highlight with this circle just to help you find these answers or find these results in the table. We see, if we're to the right of the vertical line, we have a positive effect. And if that horizontal line cutting through does not cut across the vertical line, that means the effect is also significant. So for modern contraceptive prevalence, for ART coverage, we have a significant effect. And then for skilled birth attendance, we have a positive effect, although it's not statistically significant. So across this, we have the positive effect. We can also see then if we look specifically at other types of aid, total health and the reproductive healthcare ODA, we also have a positive effect, but slightly different. So it's mainly for comparison. But what does this mean? It might be relatively abstract. So let me try to exemplify it. So take the case of contraceptive prevalence rate. The average contraceptive prevalence rate in low-income countries over the period studies was 30.55%. And the average SRH ODA during the same time period was $3.85 per capita. And if we take the results and consider what it would require to go to, say, 35% contraceptive prevalence rate, it would require $10.4 per capita. So moving from 30.55 to 35%, according to the results of this study, would require an increase of $6.5 per capita in SRH aid. So more than a doubling. That gives you a bit of perspective that, we have a small effect, you could say, but it still is a significant effect. So that's what it translates to when we say that $1 would be a 0.628 percentage point increase that you saw on the previous slide. So what does this tell us? Well, one thing it tells us is that it's probably not realistic to think that aid alone will solve the challenge of increasing contraceptive prevalence rate, but we'll get back to that. So moving on to additional results. Another thing we note is that the effect of aid has increased across the time period. What you see here are the same service outcome measurements: contraceptive prevalence, skilled birth attendance, and ART coverage. And as you see, there's a slight incline to this curve, meaning that the effect is increasing. And we see it, turning down a bit in the latest time period for modern contraceptive prevalence rate. But generally, there's an increasing effect over the time period, going from 2003 to 2020 in this diagram. And we discuss in the report if there is what we call a learning effect. There's some literature out there arguing that it takes time to go from commitments to disbursements to outputs, activities, and actually achieving impact. And that could explain, this learning effect could explain that we see an increasing effect, but we also argue that this study alone will not give that answer. It needs to be further studied to understand if there is such a learning effect. Another result that we present is that aid needs to reach a certain level to be effective. And what we say here, I'm going to highlight the results for you again. You see that if aid is at a very, very small share of, in this case, government health expenditure, so putting the size of SRH ODA in relation to government health expenditure, how much the recipient government spends on health. If it's very small, there's a limited or even a negative effect. But as you get up, you see a significant and much stronger effect when it's between, in this case, about from 8. It's a bit different percentages depending on if it's ART coverage or contraceptive prevalence or skilled birth attendance. But as it gets up to 8, 9, 10% and higher, you see the effect getting stronger. So we argue that maybe it needs to be at a certain level to actually have some sort of material effect on the available resources and policy effectiveness. So it might not be that strange that you don't have the same effect if the share is very, very small. Another thing we note in the report is that the effect of aid is larger in low-income countries than in lower middle-income countries. Here again, highlighting that here we compare the same indicators, but looking at the two different income classifications, and we see a clearly stronger effect. And this could be linked to what the threshold effect we saw earlier, that it needs to be a certain share to actually be effective. The final result I want to share with you is that both bilateral and multilateral aid has been effective. So here we look at the same indicators, but divided by the source of aid. And this might be a bit technical to those not super interested in development assistance, but we talk about source and then we talk about implementing channel of aid. And here we talk about the source. Where does the money come from? We haven't looked at the implementing mechanism. One reason being we don't have the same level of quality of data, same time series of data for that. But if we look at measured by source, we see that bilateral aid is slightly more effective, or in some cases relatively more effective. But both of them are effective sources of aid. That said, again, we're not comparing them and looking at how effective they are in terms of implementation. So having, given you a very, very brief overview of our report results, what conclusions can we actually draw from this? Well, we draw a few. There are probably more. Aid can be an effective means to increase the supply and use of SRHR services in lower middle income countries, we say. So we argue that our findings support investments in SRHR. And we had an op-ed in Svenska Dagbladet a couple of weeks ago where we also made that case. And this has been a long priority for the Swedish government. And our results lend support to the overall picture that SRHR aid has had a positive effect. The effect of aid might be increased if ODA is concentrated to low-income countries. We draw that conclusion based on the fact that we see a stronger effect compared to lower middle-income countries. That said, one should also keep in mind that ODA alone is definitely not a recipe to fix anything. We need to increase effectiveness of development assistance, and we need to, maybe even more importantly, continue mobilizing domestic resources. ODA will never be able to provide sufficient resources to really tackle the magnitude of the challenges many of these countries face. We say that development partners should enhance efforts to collect and make available higher quality data on SRHR outcomes, services, and aid allocations. We note serious limitations in the data. We set out this project with the ambition to also include, not only, now it's very SRH focused, but we wanted to have SRHR. But the reason we landed in SRH aid is that it's much more difficult to draw the line on what aid to SRHR means. And also, what do we actually measure in terms of outcomes? There's not at all as much or as good data available on that. So we argue then also that future studies should focus on both the quantitative and qualitative aspects. And this is only one piece of the evidence that we are able to provide with a study like this. So before I hand back to Julia, just leave you with a few reflections and thoughts going forward. And we asked, ourselves, if you work at SIDA or another donor organization and you're sitting there, trying to take decisions about what to do, how useful are really these types of studies for implementing SRHR aid? Maybe not super useful. They provide, as I said, one piece of the evidence, but what other pieces of evidence do we need for effective SRHR aid implementation? In the report, we argue for what we call a patchwork of evidence, different types of methodologies applied, different levels that we study this, need to collectively make up an evidence base to be able to make evidence-based informed decisions. We also, again, note this lack of relevant data and indicators on more rights-related issues. And that would be something that would be great to tackle going forward. With that, I say thank you for your attention, and I'm looking forward to this discussion. Back to you, Julia.
Thank you, Jesper. I was wondering before we move on to panel, a few follow-up questions that got me thinking. One is that you talked about that the evidence that you see, or the findings where you see a small but significant effect of SRHR aid. What does that mean for a policy maker? You could also have a small effect. Is that good enough? Is it worthwhile putting aid into this issue if it's just small effect? If you'd compare, just put that in a little bit of a context. What's your advice for a policymaker regarding that finding?
Yeah, no, it's a difficult phrasing, and I understand if it's not super clear, but I think it's, of course, it's definitely worthwhile. I guess it's small. It's more of a way of describing what you can expect in terms of return on the investments that you make. And looking again, comparing to the size of ODA, I think, when we listen and say, oh, we only need a few dollars more, that can sound also relatively cheap. But when we put it in the perspective to actually what amount of resources do we have available, it's not that small anymore. So I guess it depends a bit on how you see it, but it is a clear effect. Maybe that's a better word. So it's definitely worth investing, but we should also be aware of the fact that it can only make, a small or marginal contribution. That doesn't mean it's unimportant.
Okay, that makes sense. And how would you describe this study or the findings, what you've seen in this study compared to other reports on this topic? Is it different from what you've seen before in your research?
Both yes and no. I think, there are studies have done similar type of work. What I think, we do a pretty good job compared to some of the other work is to contextualize it to SRHR or SRH more specifically, and make that more clear cut. We're also looking at a relatively long time period, but most of the studies that we found for this actually see a positive effect in various ways. And so it becomes a bit technical, I would say, the differences in terms of exactly what methodology you apply or what you control for. So in that sense, at the first glance, these studies can sometimes look relatively similar. But when you look into the details of it and you realize, they have controlled for different things, they have looked at the slightly different time periods or cut the aid cake, if I may say so, slightly differently. But generally, it points to a positive effect, I would say.
Which you think is confirmed by other reports as well?
Yeah.
Okay, interesting. And this threshold effect that you talked about, sort of that a donor needs to reach a certain level of funding before you see the effects that you describe. Again, sort of what does that mean for a policymaker? Should Sweden in that case focus its SRHR on fewer countries, or is it sort of not worthwhile giving out sort of small project or spreading too thin today? What can a policymaker make of that?
Yeah, I think the overall answer is that yes, you should probably focus your resources a bit more. But I think again, a really boring answer, it probably needs to be unpacked a bit further to give a very a more nuanced answer to this. It's definitely. We see clearly that when we look in relation to government health expenditure, which we think is a good comparator for this, it needs to be at a certain level. But then that said, we also know that some aid efforts or aid programs are much more focused and on a general picture of things, not necessarily contributing to a bigger picture. And then sure, smaller contributions could definitely make a difference. And also we have looked at service delivery, right? We haven't looked at maybe other types of interventions or programs that you want to work with as a donor or as an agency giving development assistance, where you work maybe more on dialogue and trying to influence policies in different way.
Before we invite the full panel, I'd like to ask Jessie, you were part of the team collecting data into this massive amount of data, actually, into this report. What were the challenges that you faced in terms of finding that data?
Yeah, so regarding the data, as Jesper outlined already in the presentation, we decided to focus on the more intermediate level, so the services rather than the further downstream outcomes. And we went in very ambitiously, wanting to really to touch on the unmet need, but then also realizing we have to focus on the data that is actually available. So if we, for example, look at the contraceptive prevalence measure that we used, it's focused on the women of reproductive age and married women of reproductive age specifically, which definitely doesn't give a whole account of the unmet need that is out there. But then we also need a long time period, and we need the data to be as complete as possible. So it's like you have to compromise on your, to have the best measure conceptually or the best measure from a statistical point of view. So that's definitely something we were faced with in terms of data. And also something that's often much more looked at is what are the qualities of the recipient countries. So for example, are they lower income or they're lower middle income? What's their governance quality? But then another factor that should be probably looked more at is how are the donors behaving? How fragmented is the aid that we give out? How predictable is it? And yeah, that's also something that would probably need to receive more attention still.
Okay, good. Further studies. Björn, third party of this author team. What do you hope? What's that you have contributed with in terms of Swedish aid, perhaps in particular? I know you look at the global aid, but how do you hope this report will be used?
So we obviously hope that this will, this type of study and what we've done will be reviewed and used as a small piece of evidence that can help policymakers, decision makers to make better decisions and prioritize among competing needs. One of the things, we're looking at a 20-year period, but over this period, we are facing a very, very different situation today compared with only 10 years ago or 5 years ago even. We have had the COVID-19 pandemic that caused a lot of problems, and it exposed a lot of weaknesses in systems. It created new problems and challenges. We have a full-ranging war in Europe, and we have a full-fledged climate crisis. And all of these challenges will require very, very tough decisions on how to prioritize and allocate resources. And we hope that this report would be a small but relevant piece of that evidence eventually. I think that pretty much summarizes what I hope that we have done.
Okay, thank you. And with that, we are soon going to move on to inviting to a full panel. Just to remind everyone listening in on this that you are more than welcome to send in questions to the authors, or if you have later to the panelists maybe, and use the specific question tool that you have in Zoom to do that. And we will return to questions in about 40 minutes. So with that, I'm now going to invite the other people in the panel that have all read, I hope, the report, and talk a little bit about the findings and other challenges, maybe and opportunities in terms of sexual reproductive health and rights, and the role of aid in that in particular. So I first want to welcome Sarah Thompson, Lead Policy Specialist for Health and SRHR and at CEDA. Welcome.
Thank you.
And we also have Caroline Cabiro, Head of Sexual and Reproductive Maternal, Newborn, Child and Adolescent Health Unit at the African Population and Health Research Center. Welcome to joining us.
Thank you.
And as the third guest, Alvaro Bermejo, Director General, International Planned Parenthood Foundation, IPPF. Welcome.
Thank you, and good afternoon.
For the sake of transparency, I forgot to mention that before I joined WaterAid, I was a long-term professional work. My professional career was within SRHR, which is also a member association of IPPF. So now we all know that. That also means I know a little bit about the topic of today. So, Sarah, I want to start with you. And then I'll move on for the rest of the panel to answer the same question. But to start, what were your main reflections reading this report? And was there anything particular that surprised you?
Thanks, Julie, and thanks to EBA for undertaking this study. I really appreciate how seriously EBA takes the topic of SRHR. This is the second time I've been in a panel in the last year and a half on SRHR, and it's really great that there's such a focus. No, the report was really interesting. I had a hard time taking off my researcher hat since I was a researcher before I came to CEDA, and so I'm not gonna, all the other questions I have on methods and what you controlled and didn't control for Jesper, I will save for another chat. I think the report is interesting and certainly is welcome, especially given the conclusions. Anything that surprised me, perhaps I was definitely not surprised that SRHR ODA has an effect on SRHR. It would have been terribly depressing if it hadn't, since I've dedicated my life to this. But I was a little bit surprised about one of your conclusions in the report, which is that you you said that you recommended you may have to increase ODA relative to the size of domestic funding in some partner countries. And the common discourse right now amongst development partners is that domestic financing for health, including SRHR, needs to increase relative to ODA. And of course, Björn mentioned all of the challenges of making that happen. So that's not going to be easy, but that is the way the discourse is headed. So that conclusion surprised me a bit. I noticed that Jesper qualified it a bit in his remarks now, but in the report it does say that. So that surprised me. But the results didn't surprise me terribly, no.
Thanks, Sarah. And of course, we will let the authors come in after this round just to, if you have any comments or reflections on what you just hear now. Alvaro, what were your reflections reading the report and any surprises?
Yeah, thank you. And thanks for letting us comment on this important report. I would say overall, the conclusions, like Sarah, not surprising, but I think it's important to situate them in the political context that we're living in, where there is a louder growing opposition towards aid, which tends to want to press the case that aid doesn't work and it goes to line up corrupt pockets. This study shows no evidence of that, shows that certainly SRHR aid is having a positive effect, something that, like Sarah has said, we also knew at IPPF, but it's good to see that documented. So I would say the one thing that surprised me, and I sort of object a little bit to, and you've reacted to, Julia, as well, is the characterization of this significant positive effect as relatively small. And let me just say two words as to why I struggle with that. First, because people might understand that it's relatively small in the sense that the outcome you get from a Swedish dollar in SRHR is more than what you get with a Swedish dollar in SRHR aid, or bigger than you get with a low-income country dollar spent in SRHR. But the report isn't saying that. So I think that's important to clarify it. And Jesper has done that when talking. So as he has said, when he says it's relatively small, what he's comparing it with is what it would be needed to reach the equitable global target set for the outcomes that we have studied. And he had said, probably not realistic to think aid alone would be sufficient. It definitely wouldn't be realistic to think that aid alone would be sufficient. And I think it's really important that we don't even suggest that development aid and charity would be the main solution to maternal and infant mortality, to bodily autonomy, or HIV mortality, because even that idea is already distorting and damaging. So I would instead argue that there's nothing relatively small in this effect. The significant positive impact on the intended outcome is rather a powerful demonstration of the value of global solidarity, which will lead to grow together with domestic funding to achieve a more equitable world. And I say this because words and framing does matter. And articulating a vision of change where aid is seen as an element of global solidarity to add to the domestic effort is the first step towards achieving that global solidarity. And in that sense, I think highlighting the power of aid, in this case demonstrated by this study, is more important than highlighting its smallness relative to the domestic contribution. So that was my only comment. And it's not about disagreeing with the message of the report. It's more of how we use words to convey that power a little bit more.
Thank you, Alvaro. I'm going to quickly hand over to Caroline. I'd love to hear your reflections and any surprises. And then I'm going to hand over to Jesper, Björn, or Jessie to, if you have any reflections on what you just heard.
Sure.
Please, Caroline.
Sure. Thank you so much for the opportunity to participate in the panel discussion. And for me, perhaps unlike Sarah and Alvaro, because health financing is not my area of expertise, I found the report and the presentation to be quite enlightening and thought-provoking. And I was particularly intrigued by 4 of the findings around the positive effect on access to contraception, skilled birth attendant, and ART. That large increases in those indicators would require significant increases in aid. And then that government health expenditure as a share of current health expenditure does have that statistically significant effect. And I was also intrigued by the findings around the marginal effects of aid on SRH services. And I agree with the authors about this showing that there's a need for continued SRHR aid. But I also felt that it's also useful to reflect on the findings around the increasing focus on countries being able to fund health through domestic funds. And that aid is actually directed to those aspects that bring the most value. So I at least I know within Kenya, and having been part of a discussion 2 weeks ago, where it was on SRHR, but one of the key areas of discussion was around domestic funding for health. As I was reflecting on the findings vis-a-vis the discussion that we had at that meeting, it's what role really do donors have in helping countries achieve that ambition to really have healthcare financed through domestic resources? And then another thing that I just wanted to briefly reflect on is that finding around aid appearing to have or having a larger effect in low-income countries, and how that may drive decisions to focus aid on low-income countries. And yet we know even in low and middle-income countries, there are significant disparities. So yes, nationally, there's that average showing improvements, but even within lower middle-income countries, there are significant disparities and they're hard to reach populations. And we wouldn't then want to see that the conversation is that aid should be directed only to low-income countries at the expense of those inequalities not being addressed. So thanks.
Thank you, Sarah, Alvaro, and Caroline. I'm wondering if the authors, if you have anything that you want to share in regards to this. Jesper, please.
Thank you, and thank you for those comments. I think it illustrates, one of the challenges in taking on this. I mean, I on the one hand, I think, the results speak to themselves. We have looked in relation to government health expenditure, and then you can measure a certain effect. But of course, at the end of the day, for the positive outcomes, we are not super interested in where the money comes from, right? If it's domestic resources or aid. But it happens to, and maybe therefore it's not super strange as well that you see where you have a large share of the expenditure, that you actually see a bigger effect. It doesn't mean that you have to concentrate automatically. And I think it also speaks to, adding another dimension to it, I think the Lancet Commission on Investing in Health, which was one of the first EBA reports we had 10 years ago, and I was part of writing it, a big argument in that report was that aid in terms of actually filling a financial void, a financial gap, is first and foremost of importance in the very most resource-constrained settings. And I think, adding this piece of evidence to that overall sort of idea of aid playing a role as filling a financial void, speaks to maybe a larger share of concentration to the poorest countries. Because also where you have a larger domestic resource envelope, which is what we all want, will not be those countries that will will benefit the most from development assistance. So I think I totally agree. It needs to be seen in a bigger picture of things. Thank you.
Thanks. I see no other hands, so want to move on to Sarah again, coming back to you. And Alvaro mentioned sort of the current political context, and narrowing it down to the current Swedish political context. SIDA was assigned in the letter of appropriation to provide an input to or investigate sort of a possibility for a potential new global strategy on SRHR, sort of specifically. I'm wondering if you want to share a little bit about that process, and perhaps specifically, if you during that process found that you what sort of reflected upon sort of what kind of evidence or knowledge and data are in fact needed in designing and programming Swedish SRHR aid.
Thanks for that, Julia. Yes, I was involved in that process. It was really very stimulating and very interesting, and we were able to draw on our Swedish partners, our global partners, and all of the very knowledgeable staff here at SIDA to give input. And we got so much great input, and the sort of what we suggested were sort of three buckets that we felt would be needed in order to increase access to SRHR for the neediest, for adolescents, for people living with disabilities, for LGBTQI people. And the first one was around democracy and human rights, rule of law, giving voice and agency to really building up grassroots movements, which we're doing to a great extent, but to make sure that that piece is there. And the second piece was very significantly for this discussion was focus on building up the health system for sexual and reproductive health. And there is, in my view, there is no SRHR without access to services. SRHR is bigger than just access to services, but without that piece, we will not have efficient and effective SRHR development assistance. So that was the second piece, and it was also around, you know, how do we increase domestic financing, what we've just been talking about here, and some of the ways that that could happen, but also around governance and anti-corruption, which this report also mentioned as being important in this study. And then the third area was, I think, coming to the question that you asked me around what more evidence is needed, was around other social determinants, other determinants of health, such as WASH in healthcare facilities and schools, obviously girls' education, keeping girls in schools, but also girls' economic empowerment. Does having a little bit of cash in her pocket help keep a girl in school and thereby keep her from being married off and getting pregnant early, for example? And I know that there is, it's a topic that interests me a lot. So I follow this research, and we do fund some of this research through some partners. But the connection between social protection and SRHR, I think, is understudied. And also, you know, governments want to know what are, because this ultimately is, we want governments to take over, not that these programs are funded forever by development partners, but government wants to know what are sort of 2 or 3 interventions that they can put in order to improve the sexual and reproductive health of, you know, population A, adolescents, population B, married couples. Let's say, how do you reduce intimate partner violence, elderly people, LGBTQ people. And so they want to know sort of very specifically, amongst all the potential interventions, what are the big wins, where are the big wins? And I think that's where we need more research. There is some going on, but, you know, what is the sort of combination of, yes, sexual reproductive services, yes, you know, movement building, but then the other things like food, like cash, like parenting skills, safe spaces. So that's one area anyway. And another one, I'll just say one more that I feel really strongly about is very much needed, is we talk a lot about the need to invest in anti-corruption programs in the health sector. How do we measure the effect of such programs? Obviously, every dollar that's stolen out of a system is one less dollar that goes to improving sexual and reproductive health and the health of populations. But and we do have programs, and we could and should do more in the healthcare system. But how do we measure the effect of those programs?
Thank you. That was a long list, and I heard sort of EBA is we're just scrabbling down to see how we can work with that further. Thank you for that, Sarah. Caroline, I have a rather similar question for you, also representing here a research center focusing on SRHR. So where do you see the biggest knowledge gaps as of today?
Thanks, and I fully agree with what Sarah was speaking about research on the social determinants of sexual and reproductive health. I think just thinking about this particular report, which focuses on just 3 SRH indicators for very sound reasons. It would also be valuable to know what would be the effects of aid on other indicators for which relatively good data may exist. And so that would be something else. And some of the outcomes, for example, female genital mutilation, gender-based violence, for which they are good indicators, though those are more at the outcome level. Further, beyond determining the optimal level of aid, I sort of feel it would be critical to unpack the specific forms of support that lead not just to change in specific health outcomes when aid is available, but that lead to sustained change over time. And so that might be more of the investments in health systems, the corruption, but then of course it does raise a question about how you measure those. I also feel like it's important to have studies that reflect the views and perceptions of stakeholders in the recipient countries. What are their views about the role of aid? What are their views about the benefits? What are their views about the challenges that come with that? Because it then ensures that we have a global picture, not just from one perspective, but even from the recipients themselves and how they view aid as being important in terms of driving change in SRHR. I also think now, just beyond research and evidence, I think, and I think Jesper spoke about this, around the investments in really comprehensive data systems that address the data gaps that were highlighted in the report. I think that would allow for continual learning and adaptation, both by donor countries and local governments as well. So just some quick thoughts. Thanks.
Thank you, Caroline, for sharing those. Alvaro, this report is focusing on these 3 types of areas that we've heard: school birth attendance, modern contraceptives, and ART for HIV and AIDS. I'm wondering for International Planned Parenthood Federation, how useful is this for you? How can you use this information in programming or SRHR interventions?
Look, it's extremely useful. We are primarily a healthcare provider, and we see sexual and reproductive health services as integral to that healthcare provision. So I would say very important. I would also say, of course, we focused on these 3 indicators, not just because they're important, but also because we have the best data behind them. It doesn't make that in itself doesn't make them more or less important than others, but it does make the study focus on it. I would say from an IBPF perspective, the best SRHR is one that really provides an integrated package of services that goes beyond these, that includes but goes beyond these 3 measures. And I would continue advocating for that. And that's where our programming is focused on. One other thing I wanted to add on is that, you know, in the difficulty to measure rights and indicators around it, which has been reflected here, we cannot forget how important they are and how much they set the context. We need to be careful not to understand SRHR as services that everybody now is trying to implement and increase access to, and which aid is slightly contributing to that. And I say this because from where I sit, you know, we're in you can see very clearly we're in this era of macho politics, where you can see a transnational community of like-minded religious extremists and related far-right actors that are making strategic funding decisions across international borders. Hundreds of millions of dollars, let's be clear, from the US, from Russian oligarchs, from homegrown autocrats, are being directed to attack sexual and reproductive rights today and to make women's and LGBT access to these services more difficult than it was before. So let's be clear, we're confronting a very clear strategy, global strategy backed by millions of dollars to undermine sexual and reproductive rights. And they do that as part of a bigger political effort. And I want to quote Arundhati Roy speaking there in Stockholm, at the Swedish Academy just in March. We're saying through these attacks, democracy is being systematically disassembled. So much so that in many countries, little more than the rituals remain. And we could use examples from not just the US or Poland or Uganda or Afghanistan, but many, many other countries. So what I would say for IPTF, what this report does provide is that evidence that investing in SRHR ODA has a positive impact on contraceptive prevalence, on skilled birth attendance, and ART coverage. But, or in addition, there is an even more compelling reason to invest in SRHR globally, at home, here in Europe, in Sweden, as well as abroad, because that's the only way to maintain progress towards gender equality and to preserve liberal democracies as we currently understand them. So if you were to add these effects to the ones that have been documented in the report, I would argue there's an even a bigger case to invest in SRHR, both abroad and at home. And it is clear that Europe requires more investment in Europe as well. Thank you.
I'm wondering though, Alvaro, just to follow up on that, sort of in terms of, because we've seen the challenge in terms of data here, and sort of if we want to focus on evidence solely as a means of making a decision and priority, we've sort of, that narrows that down a little bit in terms of for policymakers sort of to what do we know if that's sort of the only thing that we want to make a decision on, basically. So, but you're talking about sort of a much wider political context where maybe evidence isn't the sole base for a political priority. There's another aspect. How do you, I'm sort of guiding the question to you, but if anyone else wants to answer, you're welcome to sort of, how from a decision-making perspective, what advice would you give a politician in terms of bringing all those aspects together? Sort of, there are evidence that we need, but we also have sort of a fundamental moral aspects or political aspects, or are there other things? Sort of, as giving advice, you now have the opportunity to give advice to the Swedish government, maybe hopefully listening in it. What would that be? How to make that judgment call?
So there would be three things, and I didn't get a chance to respond, Julia, to get the question of, what additional research is needed. And I would argue, and we're investing in that, but that more scientific research needs to go into investigating, into documenting the actions that this anti-gender, anti-SRHR movement are taking. So I think that's an area where a lot more research is needed as to how this patriarchal and this hyper-capitalist and this anti-liberal and religious agendas have come together to find this common place, this attack on women's bodies and on women's rights. So I would argue more investment in understanding that and documenting that and researching that is definitely a priority going forward. Then I do think also measuring our impact on rights, and you can use measures around mental health and around agency as sort of indicators of where we are progressing in that area. We could be looking more at those softer measures of empowerment, agency, and development as well, and how SRHR and comprehensive sexuality education sort of contribute to that. And then, because I believe that through giving women and those that don't identify in our binary world more agency, you also start building more equitable societies. I think we could also be looking at sort of measures of equality and equitable societies as outcomes of both comprehensive sexuality education and SRHR investments, and that would be a very important area of research as well. So those are three areas where I think the current political environment sort of act as an incentive or as a trigger, as a catalyst for speedy research in these areas.
Thank you. Sarah, we've heard a number of areas that we've already identified as gaps in terms of research. What do you, representing here as sort of a donor community, representing CEDA, what do you think the responsibility of donors in contributing to knowledge about sort of what we know about effectiveness and SRHR? What's the donor's role in this regard?
Oh, there's so many different levels. There's maybe not just one responsibility. I mean, we are part of a greater ecosystem, of course, including researchers and our civil society partners, the UN, all of whom we also fund. So we have to say that, you know, in a way, we're funding this research through different mechanisms. So to continue, especially to fund research, building up research partnerships and cooperation as we have been doing for many years. And some of the, within SRHR, I would say the mechanism that we're very proud that we support and I think could use much more support, and we are definitely trying to rally other donors to support, is the joint UN Human Reproduction Program it's based at WHO, because they are the motor for a lot of the normative work done around SRHR. For example, they released the updated guidelines on safe abortion that apply to every single country in the world, including Sweden. And we've been funding them for 50 years. And so, yeah, thanks to CEDA, we have, and others, we have good guidelines, evidence-based guidelines. And that's just one of the many different products. So I'd say, if we want these organizations and mechanisms to continue to, including academia, to continue to challenge what we do, but also to contribute to how governments around the world actually implement SRHR, it's incredibly important that we continue to fund them. Then as an agency, in terms of what we do internally, one of my pet projects that was also in part spurred by your other EBA report on SRHR was on measuring, and I think it's impossible for us to measure everything we do on SRHR because it's, in effect, ideally SRHR is mainstreamed into everything we do at CEDA. That's what I think anyway. And I pushed for it in many different sectors. And in that way, it's difficult to measure it, but we're trying to move towards to be more accurate about how we fund and what we fund in SRHR, so that we can reflect that in our reporting, our annual reporting. And I know that Jesper knows this, that we do define and report SRHR in a much broader way than is done in this report. So we're including not just the health DAC sector codes, but we also include gender equality, democracy and human rights, that includes GBV. So there's, I think it's important that we're able to reflect the breadth of what we do in SRHR, and hopefully that will also contribute in some way to the knowledge base.
Thank you, Sarah. I'm going to let Björn in, and then I'll move on to you, Caroline.
Thank you very much. And thanks to Alvaro and Sarah and Caroline for very good comments and reflections on the report. What we have done is, as researchers, we ask questions. And if the questions are good, we're not afraid of the answers. We're not surprised by the answers. We provide the answers, and hopefully to good questions. And in this case, we provide, questions that may provide support for continuing doing what we want to achieve, namely to address these, improve these services and eventually improve these outcomes. Nobody here needs to be lectured on the importance of sexual and reproductive health and rights. There are two things that I think that we discussed as concerns. One is the continued lack of good data on many of these services and outcomes. We've been doing this, we've been collecting, organizations, WHO, World Bank, et cetera, have been producing data for decades, and they continue to be used basic to fill out Excel worksheets. But we wanted to actually use the data for analysis, and that's what we tried to do. The other thing is, I'm not sure that, given the drastic changes that have taken place in the overall context, that partners have actually adjusted and adapted and understood the implications of these changes, and that I think needs to happen. We are pointing in some directions as to how support and aid in this context may need to adapt and adjust and become more effective. In November, at the COP27 meeting, countries will ask for not billions, but trillions of dollars to fight the climate crisis in terms of adaptation and adjustments. And that will have enormous consequences for the overall role of development assistance, I think, including in this in this case. Thank you.
Thank you, Björn. Caroline, I wanted to bring us a little bit back again to sort of the importance of creating that knowledge base and research. Coming from working for a research center, and you have done a dialogue with a lot of donors, what do you see is there an interest in supporting research, also in the context that aid is getting, as we mentioned before, more scarce and donors are cutting down? Where does research fit in that agenda? Is there something that donors first move out from, or do you see that there's an increase in interest perhaps in knowing about what effects and results there might be?
I would say that there is an interest in funding research, because in addition, there is that push for evidence-informed decision-making. So there is keen interest in building capacity, both for research, but also in terms of generating research for sexual and reproductive health, and in particular in how that research gets into the hands of various policy actors who can either use it for advocacy or for decision making. And we do receive significant funding from CEDA for some of this work, looking at research on contentious issues, adolescent sexual and reproductive health, abortion, and LGBTQ rights in sub-Saharan Africa. And I think that has been critical in opening conversations and dialogues around these issues. So I would say yes, that interest remains, and it is important. But I think just to reflect on some of the findings, I think the focus on research, not just on the health outcomes, but also on the rights outcomes, is something that's quite critical. I know now there's a lot of focus on social norms change. How do you change social norms? And how do you measure that change that happens as a result when social norms actually change? How do you measure that? So I do feel that there is that interest, and it would be useful to see a greater focus on the rights aspects of sexual and reproductive health and not just the health outcomes, so that we are really looking at SRHR comprehensively. Yeah, thanks.
Thanks. Sarah, one last question to you before I'm opening up. I'm going to read questions from the audience. But Sarah, how do you know that you're doing a good job? What does success look like in the end of the day? You're muted, Sarah.
Ultimately, we want, of course, to see positive outcomes as impact, as Jesper said in the beginning, but there's a problem of attribution, of course. And so, you know, how do we know that at the population level, which is where most of the results are measured, in whether it's demographic health surveys, whether it's the UNICEF mixed studies, different types of population level research, is very difficult to show that CEDA had an impact. And that's why this type of research that Lund University did is interesting. At the sort of intervention level, it's easier because we ask our partners to, with a very rigorous system of following up, baseline, midterm, and end line. Let's say if there's a program that has 1 million girls involved, what percentage at those different points actually were married off early or had an early pregnancy. So at the project level, it's easier to see, and we do frequently do both midterm reviews, which are more internally focused, but of course, external evaluations in order to share those results with other partners. But the difficulty is that that's at the intervention level, right? And we're a small donor. Let's not forget, I would say the elephant in the room in relation to this report is that U.S. funding of SRHR at any given year is at least 5 times greater than any other single donor. So, what we're doing is we're trying to complement domestic financing and, the big funding coming from Global Fund, which we also fund, but through the ministry, Gavi and let's say PEPFAR, the big HIV programs. And we're complementing them with programs that focus on topics that donors don't necessarily fund, which Caroline referred to, the research in Africa on access to safe abortion, sexuality education. So it's difficult to say, I'd say, what kind of impact we're having at the population level. It's just really difficult. But at the intervention level, we definitely can show results.
Thank you, Sarah. Okay, are you ready? Full team of panelists and authors. Here comes questions from audience. And please respond as quickly as you can so that we can, or as clear and distinct, of course, but we want to be able to have time for many questions. Question from Ilo. Did the study assess the risk that organizations are taking by implementing programs and projects, especially with the emergence of the anti-SRHR movement attacks targeting activists? So was there a risk analysis in the study? I'm gonna let you answer directly. I think yes.
No is the short answer.
No is the short answer. So that's for another study, Elon.
Yeah.
Given the strong forces opposing SRHR, are there areas that are easier to find consensus about, areas that for strategic reasons should be promoted first? Good question. I'm gonna ask you to raise your hand after each question to see, so I'm not gathering a lot up. So I have Alvaro and then Jesper, please. Alvaro, please.
There are, and I was partly referring to that. These areas that are measured here are in some way the easier ones of the SRHR package, the less controversial ones, let's put it that way. But that doesn't mean they should be tackled first or that they should be invested first, because by doing that, what you do is isolate the more difficult areas and make them even more difficult to fund, and begin to then feed a narrative that says that these areas are healthcare, abortion isn't. Abortion is something else that we should not play into. And I'm thankful that Sweden doesn't do that, and that Sweden has continued funding as a package, as Sarah has said, really focusing on the more difficult areas. So I would argue it needs to be promoted as a package, but there are definitely areas that are easier and that this big funder that Sarah was referring to tends to prefer.
Okay, Jesper, you also had a
I have nothing much more to add. I mean, I totally agree with what Alvaro said, and then just a reflection from a meeting last week in South Africa where we met with ministers of health from countries in the region, and it was my same feeling. You know, what we're not studying in this report is what is difficult. The other things, you know, it's relatively straightforward. You know, what can be included in country basic benefits packages, and that is not related to these controversial issues, for example, abortion. It's relatively unproblematic, and maybe that also speaks to the lack of data.
Okay. So a third question. What should a good balance between support to global initiatives working on norms and support directed to country level? Is there a balance between global norms and standards and support direct to country levels? Should focus be on one or the other if resources are scarce? I know Jesper and Björn, you touched upon this a little bit in the report in terms of bilateral versus multilateral. Do you want to go into that?
I think Sarah would have a much better answer than if we look solely at the results from the report.
And I'm actually now unsure if I understood. You said that the balance on norms. Do you mean like social norms?
I think the person here refers to sort of global standard norms.
Norms and standards.
Normative SRHR global focus rather, or country bilateral aid standard. Sorry for interpreting the question.
Yeah, because there are different ways to interpret normative, but when I was speaking, it was in relation to standards and guidelines, that kind of normative work that WHO is really responsible for in terms of health. And there it's incredibly important to continue that funding of WHO and HRP, as I said, WHO broader, because so many of these issues are linked. It could be research on fistula, it could be research on maternal mortality, on perinatal mental health. All these issues are incredibly important to get good guidelines and standards. So I don't want to say one versus the other. What's important is that those standards get translated into national guidelines. And that's really where we rely in terms of what we fund, is we rely on our partners in countries, whether they be multilateral, whether they be civil society organizations, international NGOs, they could be parliamentarian groups, but to ensure, and of course, ministries of health, to ensure that those global norms and standards get translated into national, and that is an incredibly powerful piece of work. But then it's not enough, of course. So then it's actually getting access and the cost, making sure people are aware of their rights to access those services. So there are many different pieces, and I would say, I understand that there is a need to, make things more efficient, and maybe, we should just be focusing on one thing. But I do think that a good donor has a holistic view and looks at the whole ecosystem. We can't just fund multilateral organizations who work very much hand in hand with the government to implement and to put in these new guidelines. We also have to have the watchdogs and civil society, and who are reminding people of their rights and reminding the governments of the different guidelines that exist and that access isn't there.
Okay, yes, Jesper, I see you, and then Alvaro.
Can I just add, we have looked mainly at service delivery. By far, all aid is directed and meant for service delivery. And I think, one point that we would like to make, and I think the evidence to some extent speaks to that, is that in order to contribute to service delivery, aid plays a smaller and smaller role as countries get richer, right? And I think, over time, hopefully fewer countries will be poor. So there will be a smaller case for aid for service delivery, I think, over time. And we're already seeing that in countries like Zambia, who are sort of on the verge of being a lower middle income country. Aid is increasingly marginalized in service delivery. That doesn't mean, as we said, there are many issues thrown around here, which does not have to do with direct service delivery, but which are hugely important for advancing SRHR. And there, aid can play a role, but that's also done in a different way.
Alvaro, please, you had a thought on this as well.
Yes, I was very much, I think, going to add to what Jesper has already said. I always remember when I'm asked this question, a sex worker in Ukraine 15 years ago, who told me, explained to me how she's had sex in every train station, in every bed of every hotel, in every kitchen, and everywhere, but she had never had sex at the global level. And could I give her a example of where I knew any unwanted pregnancy or any HIV infection that had been transmitted at the global level, and I couldn't give her any example. So that, to me, puts that same perspective in question. Not just the services, but the infections and the unwanted pregnancies happen very much at the local level. At the same time, today, there is a global financed and globally orchestrated, globally strategized push against these things. And this does need to be fought at the global level. That's would be my argument. So as Sarah has said, we need both these investments, and, uncomfortable as it is, to keep an eye looking down to the local level and an eye looking up to the global level as well, uncomfortable as that is.
Okay. Thanks. Moving on here with new questions. So the question is, what are some potential policy implications of the study for countries that rely on ODA? So not the middle income countries that we talked about, or low middle income countries, but sort of really the most low income countries. Sorry, that was my interpretation. I can't help myself. That rely on ODA for SRHR services for the partner countries, not for the donors. Sorry, I'll try again. What are the policy implications of your study for the countries that rely on ODA for SRHR services? That is for the partner countries, not the donors. I think the question is mainly directed to the authors, so I'm looking at the three of you, if any of you feel eager to respond. Björn, please.
Well, recipient countries can take these messages on just as much and to the same extent as donor countries, because it is a partnership. In the end, that's what it is. And they need to understand this relationship in order to, have a dialogue that, provides and creates hopefully, conditions for making aid more effective in the end. So there's no difference here really. But in terms of direct implications and lessons, there may not be that many, granted.
Jesper, I think you were on your way. Yes, please.
Yeah, one implication could be also, sort of fully embrace that idea of, it's the main solutions lie with them, and sort of to the extent they can start thinking of a context where they're not relying on aid, and we'd like to avoid the concept of depending on aid, but rather than relying on it for certain things, and then moving over to relying on their own funds rather than external funds for service delivery.
Okay. We have one more question on relating to the opposition and risks. So here's the question. Given the emergence of the anti-SRHR movements and attacks targeting activists, what are the risks to different stakeholders involved in the promotion of SRHR, and how should donors contribute to tackling those? Sarah or Caroline? I think maybe, or if Caroline, please.
Sure. I think the risks are many for those who are involved in the SRHR field. Recently, I was having a discussion with someone from government and asking them what their views were around the law in Uganda. And she said, I hope that activists in Kenya will not use this opportunity to raise the issue and bring it to the attention of government officials, because what that means is often then programs like HIV services for key populations are affected. So I almost feel like it's important for people to understand the norms and views of people locally, and sometimes to realize that you may be able to move a step forward by tackling rights issues indirectly rather than directly. The same thing with comprehensive sexuality education. If you just hear the average, and I'll use Kenya as an example, they say, why would anyone call anything comprehensive sexuality education? And would we have made more headway had we used a term that is more acceptable to the population? So sometimes I think we agree with comprehensive sexuality education. We believe the content is critical, but sometimes I think we also have to listen to those that we are engaging with and what they are uncomfortable with, and not throw the bucket out with the water. And I know there are countries like the West African countries, they did have an agreement or commitment around what is comprehensive sexuality education. But if you look at that entire document, they don't mention comprehensive sexuality once. And I think those are sometimes things that we need to think about as SRH researchers, SRHR advocates, that sometimes we really do have to listen to what people are saying and be willing to take bold steps sometimes, which may be around even the terminologies that we use, and being careful. Like I said, the government official says, if this issue, if the activists then start raising a lot of questions around the law, then lawmakers who do not understand what we're trying to achieve then say, move things in a certain direction, which then has direct implications for health service utilization. I don't know if I'm communicating that clearly, but the main thing is that we really do have to take some time sometimes just to stop and listen to what others are saying and think around innovative ways around communicating what we want to say in a way that doesn't antagonize people. Thanks.
Thank you so much, Caroline. I think that was very clear. I see you, Alvaro, but we are going to round up now. I have just one more very distinct, maybe easy question to answer before we round up. And this is children and youth access to SRHR is often considered especially sensitive. Do you know how much of the services that you studied reached children and youth?
I'm looking at Jessie for help here. Do we know that based on the data that we have used?
So as I already mentioned, the data is still very limited, especially if we're talking about complete data. So for example, for contraceptive services, this is a huge issue among adolescents, and we would love to see data specifically focused on that, or stratified data, but that's currently not available. So we would love to have included such considerations in the analysis, being aware of the issue of sexual reproductive health and rights in younger ages. Skilled birth attendants, the same thing, especially with young mothers being afraid to seek out treatment that they need when they get pregnant, or like the barriers they face regarding norms in countries. So we would have loved to have that data, but currently that was not included.
Okay, thank you. So with that, I would like to extend my huge thanks to the author team and of course the panelists coming in and sharing your reflections and thoughts on that. I think we managed to cover both an interesting scope that was connected to research gaps and obviously ideas for EBA to take forward, but maybe others as well. But all in that put in a context where SRHR is part of a political global opposition and context, of course. So research is obviously important, but should be seen as part of that political conversation. I'll stop there. If you're interested in SRHR, I just want to say the previous report from EBA has been mentioned before. It's available on the EBA website. It's about SRHR and social norms. So if this got you curious, you know where to find it. Huge thanks to everyone also who listened in. I'm sorry we couldn't answer all your questions. There's a whole bunch of lists that I couldn't manage, but I appreciate your commitment and curiosity in this regard. So big thanks from EBA and everyone else.